All right, all right. So on this episode, we're going to be talking about tendinopathies. Like tendinopathies for me were probably, certainly weren't the first thing that kind of made us get into acupuncture like really seriously, but they were definitely something which fairly early on made us think, oh, right, there's something in this. There's something special about acupuncture and dry needling. I'm kind of thinking back to the early days of my practice. You know, you were seeing the chronic back pains, you were seeing the headaches and migraines. And I think why I navigated or migrated towards acupuncture in those days was because I just wasn't getting some great results from it, right? You know what I mean? Like we weren't getting the results quickly. We weren't getting stuff that was, I wouldn't say it wasn't effective, but it was quite hit and miss as to how much benefit people were getting. And then when I was using acupuncture in them, they was like, all right, this is actually making a difference here and there. Like people are feeling a positive result of it straight away. Tendinopathies kind of came a little bit later on, I think, because when I think about what my practice was doing then, you know, we had some fairly, well, I would say okay evidence base, and we sort of had a bit of a structure as to how to deal with tendinopathies. So it was, I mean, no, I'm probably showing my age here, but like going back to those, thinking about like loading of tendons was quite right at the beginning of that concept of where we're thinking, right, we don't want to just rest the tendon. We don't want to just stretch it. We don't want to ice it. We want to start moving on to thinking about loading. So that Alfredson movement of, you know, just basically just load the tendon. And if I remember correctly, the story goes that Alfredson was had developed a tendinopathy of his Achilles, had found that there was a huge waiting list waiting for like a surgical operation. He was like, right, well, to expedite this, to make sure that I get surgery even quicker, I'm going to make the tendon snap. So what he started doing was just like really loading his Achilles tendon, super lots, like loads and loads of weight, trying to make the tendon snap. So then he would be like more of an emergency case or more of a priority case to get his tendons repaired. But then the process of doing that found that actually his tendinopathy pain disappeared and got rid of it. And there was born this kind of idea of this acute loading of the tendon to try and benefit it. So I remember us talking about that, and I remember us doing that in part of tendinopathy management. And so because I had me kind of ritual, I had me like approach to dealing with tendinopathies, I probably wasn't thinking of acupuncture so early on. But when I started thinking about it, and, you know, I'm trying to like, you know, think back before I was like prepping for this podcast, I'm like, well, what kind of like made us start looking at acupuncture and dry needling? And there was a couple of instances or a couple of scenarios, I guess, to correct myself. One was that this Alfredson approach, this kind of like loading of the tendon approach, means that people had to go through a period of like intense pain, like loads and loads of pain. And that in itself put a lot of people off, right? They were like, yeah, I'm coming to see you, Carl, to get me stuff better, not make it worse. And anybody who's tried to rehab a tendon with those kind of principles, you know that it feels a lot worse before it gets better. Now, don't get us wrong, some people bought into that and got on board with it, but a lot of people didn't, right? Because they were like, well, all I'm going off is you telling me that this should happen, but my body's telling us, everything in my body's telling us, no, stop doing this. It's actually making it worse. And then you've obviously got to bring in like the actual life element of this. If you're actually making somebody's pain worse, and the principles of a tendinopathy is that it's still functioning, you're still able to use the tendon and the joint. Well, it tends to be a repetitive motion, and the repetitive motions tend to be something that they do on a day-to-day basis. So they're actually now in more discomfort, they have more disability, and they're perhaps not able to do the thing that's related to their occupation, right? So they're just like, well, I can't even do this now. I was just about capable of doing it. So that was a big barrier. And I think also as well, like, you know, as we do with almost everything, we kind of have like fads and fashions. This kind of loading stuff did have some traction behind it, and people were sort of buying into it and thinking this was something we should be doing. But it wasn't the be-all and end-all. And I think that's where I really started to mold my appreciation of acupuncture and dry needling, to think that, well, acupuncture and dry needling isn't for everybody and everything, but in fact, it can be for some people, and for some people, it's fantastic. So that's kind of like was my introduction to it. I remember one gentleman, he was He was a tradesman. He came in, he'd had elbow pain. He had a tennis elbow, a lateral epicondylitis. And we went through the whole process of doing everything and, you know, the usual treatment approaches and stuff. It probably had through in some electrotherapy in those days as well. And I remember suggesting to him, let's do some acupuncture, dry needling. He was, nah, not interested. And I was like, right, okay, this is, you know, there's not a solid evidence base behind it, but it could be worth it since we're not getting anywhere with our existing stuff. No, I want to carry on. I think we went on for another 1 or 2 sessions and he was like, oh, let's just give this acupuncture malarkey a go. Like totally and utterly, like like no expectations whatsoever that this was going to work. This was him. Obviously, I was like, this could work, but he was like dead against it. This woo-woo, like rubbish. No. He came in the next session and he was like a different guy. And he was like, he says, I left the last session and he says, I got into the van and I nearly walked straight back into the clinic to tell you that I've had no pain. So that was at the end of the session that he'd had the acupuncture in. And then since that time, let's say it was like a week, 10 days, he'd had 0 problems at all. And he was like over the moon, high five and everything, proper acupuncture convert, wearing like robes and growing a massive grey beard and poofing in grey smoke and stuff like that. So yeah, I remember that because I remember that kind of, we often talk about this on the courses about like, do you have to believe in acupuncture for it to work? And I always think back to that guy, think back and say, well, he's a really good example of where, no, you don't actually have to believe acupuncture works for it to make a difference. But he was a tendinopathy. And the tendinopathy for him responded fantastically well. And he went on and as far as I know, had a very rich and fulfilling life. Probably set up a monastery somewhere. Maybe he's took in like disadvantaged animals, polar bears and cucumber ants and all sorts of things. All right, so the prevalence of the issue, like we like to do on this podcast, we like to give some background stuff. Tendinopathies, there's a kind of range here. Somewhere between 11 to 30% of adults at some point in their time will have a tendinopathy. And then, you know, that's on a scale, right? So some people it's going to be like mildly irritating, and then to other people it's going to be severely debilitating. The most common sites in which we develop tendinopathies are shoulders, elbows, knees, and the Achilles tendon. Tends to affect mainly the 30 to 50-year-olds because they're in the overuse repetitive strain bracket. I don't really know why this is, but if I was going to hazard a guess, I think it's perhaps because the younger you're on the go all the time and you kind of, your body's used to like adapting and moving and doing things repeatedly all the time. And then perhaps when we hit our 30s, 40s, 50s, we become more sedentary. And so we have these kind of like spurts, right? We have these periods of like barrenness where we're not doing anything at all. And then all of a sudden we'll go, you know what? I need to do something here. I used to be able to run all over the shop. I used to be able to lift this weight and all that. So then you do this, go from like 0 to 100 really, really quickly. And that tends to be the thing that brings about a tendinopathy, right? So maybe that's why that 30 to 50-year-old bracket, I'm not so sure, but like I hazard a guess that's part of the reason, you know. It's a deconditioned muscle and tendon, and then it's been asked to do a lot of repetitive activity in a short period of time it's not used to doing. Recurrence rate seems to be about 30%. So if you've developed one tendinopathy, it's likely to come back. And there are things like underlying risks. There's talking about poor biomechanics. They've not actually rehabbed it properly in the first place. And definitely that's a thing you see where people have basically rested it for ages. You know, the Achilles is a great example of this, or patella tendon. It's a great example of this where, you know, people have rested it for an extended period of time. They're no longer getting the pain. They're now sedentary and they're now like deconditioned again. So they're like, oh, you know what, I need to start running again. My knee feels better and my Achilles feels better. And they just do the same boom and bust, boom and bust, boom and bust. And it reoccurs. So they haven't gone through the proper rehab process to try and prevent it coming back. Not surprising that athletes, people who are physically active, they seem to be able to develop it more. So there certainly seems to be a prevalence of about 50% in certain sports. And it's probably not surprising, you know, say something like tennis, a bit of a cliche here, but something like tennis it's very repetitive, right? And you're doing the same movements over and over and over again, and you're not getting a lot of rest periods. I would suspect, I don't have the data here to say for sure, but I'd suspect something like NBA basketballers are very prone to developing tendinopathies because they're asking to be performing high intensity a lot of the time, twice a week, sometimes 3 times a week in game situations. So that's not training, but in game situations. So not only has the tendon been asked to load significantly because they're in competition mode, but also they're not having a lot of downtime and rest time, and they're not having a lot as much time to be able to do the rehab stuff or the conditioning work. So I don't know, but I suspect NBA basketballers are fairly prone to developing tendinopathies as well. The financial and economic burden on this, it's not like your chronic pain conditions. It's not like your menopausal stuff that we've talked about in the past. It's still kind of like putting up what I've got here, like $1.5 billion annually. So, I mean, it's not pennies. I wouldn't mind having that $1.5 billion in my back pocket. I'd be able to buy loads of chocolate muffins then. And that's kind of attributed to things like NHS spending, GP visits, physiotherapy, specialist care. Workplace impacts, so tendinopathies lead to a lot of lost productivity and absenteeism. And so that bit is thought to cost employers about £5 billion a year. Now we're getting into some serious numbers, right? And you can kind of think about that repetitive strain stuff. So like your tennis elbow type approach where you've got somebody working at a computer and typing. And it's quite common, isn't it, to see people having adjustments and workplace assessments to try and prevent tendinopathies, but also to try and, when people have developed a tendinopathy, to try and keep them at work, or when they're returning back to work, that they don't have to go off sick again. We've got the disability benefits as well, so unemployment costing about £1 billion annually, and then there's potential long-term economic impact as well. So untreated or poorly managed tendinopathies can lead to chronic disability, reducing workforce participation, and long-term economic costs. I mean, this can be applied to pretty much any ailment or issue. And I think that if you were looking for a rationale or a reason to get interested in tendinopathies, if you were trying to look to, I was to say, promote your services and how you could support the general public, this would be something that I'd be looking at, some of the financial impacts, because that's meaningful. People understand the numbers. So the symptoms of tendinopathies, broadly speaking, they tend to be painful. That's probably no surprise. Stiffness in many individuals, so they'll talk about like morning stiffness or stiffness after an extended period of time of not moving. So if this was like a lower limb one, for example, if they were desk-based in their occupation, when they get up to go out the seat, maybe it's them first few steps, it's a bit like, really uncomfortable, feels like it's stiff and it's not moving as they'd hope to. In more the severe cases, you can get some thickening and swelling. So you tend to get it when there's like a reactive phase tendinopathy. So they're starting to get more swelling around the area, so it can feel a little bit more squidgy and podgy. It might look a little bit bigger than the other side. And if it's been going on a longer period of time, you can then get an area of thickening. And the area of the thickening tends to be more in the chronic pain or the chronic scenarios. You'd get weakness in the area. So you'd get weakness in the area, perhaps not only because of the tendon itself not being able to function as it'd like, but mainly or more so because of those sensitizer chemicals that surround a tendon in a tendinopathy. So like your CGRPs and your substance Ps, that's basically trying to get the tendon to not do something. And so it's kind of that behavioral input to say, stop doing something, give you pain so you're less likely to do things. And then obviously it's going to have a functional impact. So people will talk about tendinopathies as stopping them from doing the activities they want to do, or they may refer to it as, when they first start off doing a run, for example, let's say the first kilometer, depending on how fit they are, first 2 kilometers, they might be saying it was really uncomfortable and it kind of like wears off and becomes bearable. And then when they finish the activity, it's maybe not that painful, but a couple of hours later, by the beard of Zeus, sirree, yes, I know about that. So how they typically report their symptoms: sharp, aching and burning, particularly during those early phases of activity or after the activity, so after several hours. Interestingly as well, and this links into your dry needling stuff, you can get trigger points in the muscle bellies. So you might find that if somebody's describing a tendinopathy type symptoms, if you go and look around that muscle belly, so if it was, say, like the common extensors, you might look in the common extensor muscle bellies, you might find specific sore points that you as the therapist are like, right, I can feel a little nodule on there. And they're like, There you are. You've got a nice little trigger point in there. Stiffness. So again, we said that it might report stiffness in the morning. So first getting out of bed, or when it's first about just moving it feels like it takes a little bit of warming up for it to start being reasonable to manage. Obviously difficulty performing day-to-day tasks, because that's the thing that normally brings it about. There can be some emotional impact on that. I mean, it's usually frustration and I wouldn't say anxiety, but it's normally around frustration that they can't do the thing. I wouldn't say tendinopathies are as associated with the yellow flag scenarios as much as you would do with like migraines or chronic pain persistent problems. But, you know, it depends on how it's impacting somebody, particularly if sport's their livelihood or sport is their release for the stresses of day to day, then you can see how that could secondarily lead to some anxieties. I've said about who it affects, so it's about the 30 to 50-year-old bracket. Tends to be people who are in athletic populations. Now, we're not talking about elite athletes here, but people who are more active, and you particularly listen out for those people who have increased their load over a very short period of time. So you kind of almost guaranteed tendinopathy or very likely to get a tendinopathy if they've increased the intensity, duration, or frequency significantly over a very short period of time. Obviously, all of those three things need to happen if you want to develop, whether it be like muscle mass, whether it be power, strength, whether it be endurance. You have to stress, right? So you have to do frequency, duration, intensity, but perhaps not all three of those things at the same time, and perhaps with an appropriate gap between them. So those are the things that you listen out to subjectively. You've obviously got your occupational risks, so you'll be asking about repetitive activities, painter and decorators, you know, like new to the game, have they got a screwdriver or a hammer, you know, if we were thinking about upper limb stuff. So that kind of repetitive activity you'll be listening out for. Now, there are three different classifications of a tendinopathy. So we've got our reactive tendinopathy, we've got our dysfunctional tendinopathy, and then we've got our degenerative tendinopathy. Reactive tendinopathy tends to be as a result of like an acute load. So it tends to be something that happens fairly early on in a scenario where people have increased their load. They start getting a lot of tendon pain because the tendon's like, oh, this is all new. I want you to calm this down. Reactive tendinopathies usually respond quite well to rest. They don't need a lot of input to sort of get them back to square one. Certainly if people listen into the rehab advice around, you know, the strengthening work, the range of movement work, the decrease in load, but then gradually increasing the load, they don't tend to need a lot of input into that. It's when they start going the dysfunctional phase and the degenerative phase when we start getting the problems. So in the reactive tendinopathy, we're not usually going to see a thickening of the tendon, but in the dysfunctional phase, you could start to see it. And certainly in the degenerative phase, things like an Achilles tendon is a really good example of this. It's where you might feel like a big, really hard lump. Probably no surprise in that the longer or the more progressed the tendinopathy is, the more difficult it is to resolve the symptoms. So I think it's fairly agreed upon that a reactive tendinopathy I'd expect to be able to resolve. A dysfunctional tendinopathy, I would hope I could resolve it, but particularly with using acupuncture. A degenerative tendinopathy, I'm probably thinking more like I would with a chronic pain problem, which is to say that I might be able to manage symptoms, I might be able to reduce symptoms a bit, but I wouldn't be expecting, I certainly wouldn't be telling my patients, hey, we're going to get complete resolution of your symptoms here. So I think to give an explanation physiologically of why we think acupuncture is really helpful here. In the reactive tendon, right, this is a really good example of the descending inhibition mechanism. So in a reactive tendon, we've got a lot of acute inflammatory markers that are kind of in and around that area. So we've got things like substance P, we've got CGRP. It's interesting to watch the evidence base that's gone on over tendinopathies over the years, because there's been so much toing and froing between, you know, is it an inflammatory condition? Is it not an inflammatory condition? I think, you know, you still would have two separate camps here as to whether it is or it isn't. I'm kind of in the camp that I think it does have an inflammatory component to it, particularly in the reactive phase. And so acupuncture, when we do it local to the tendon, we know that putting acupuncture needles local to an area of tissue will invoke an anti-inflammatory response. So when we're thinking about things like substance P, CGRP, which are local inflammatories mediators, we know that when you put needles local to that area, it can effectively introduce endogenous opioids, which are inhibitors. So they would inhibit substance P, CGRP, and they would inhibit the production of it as well. So in that case, you can probably see the theory behind why acupuncture in a reactive tendinopathy might be really helpful, because we can clear away the things that are causing the pain, i.e. the inflammatory markers, and that should hopefully clear a path for them to get onto their rehab journey a lot quicker. I guess there is a potential danger here that if you're not educating your client, your patient, significantly, and you don't think they've grasped the concept here, there is a danger that if we're taking away that inflammatory process, i.e. the thing that's telling them to calm down a bit, then they could keep on going and make something worse. In the dysfunctional phase, what we'll start seeing is changes to the actual structure of the tendon. And where I see acupuncture's benefit here is probably less on the inflammatory side of things, although that will help. But there is some suggestions that it can make some changes to the vascular component of a dysfunctional tendinopathy. And so if we're changing the vascular component to a tendinopathy, we're actually hopefully dealing with some of the specifics of the structure of the tendon as well. There have been some very, very small bits of research that I've looked at when we stick needles in and around tendons, the impact that we have. And there are some suggestions that some biomarkers to suggest that we could either reverse the problems of a dysfunctional tendon or we could at least stop its progression. With a reactive tendinopathy, you're probably more likely to do something where you're kind of going in and around the tendon. So if it was something that you might do, say, like a surround the dragon, for example, you might do acupuncture points that are in and around that tendon. You know, at the elbow, large intestine 11, large intestine 10. They're obviously two obvious ones. Achilles, you've got your kidney and your bladder points. But you, so they go kind of in and around the tendon. But when you get to dysfunctional tendons, you might actually then start to think about putting needles into the tendon itself. So there's a herringbone technique, which literally does that. You find the area, it's very, very simple. So you find an area of tenderness on the tendon and you stick a needle in it. It's called the herringbone technique. So an interesting concept. I've definitely seen it work. I've definitely seen some people with dysfunctional tendinopathies respond really well to acupuncture. But like in almost everything we do in acupuncture, right, it's not a standalone intervention, right? We're doing this. If I'm going to be needling someone's tendon or I'm needling in and around the tendon, you know, I'm expecting them to go and do some other stuff. I'm kind of partially using acupuncture to say, right, this is giving you the window of opportunity to do the stuff that's actually going to get you better, right? So we'll do the pain relieving stuff and we'll maybe change a little bit of physiology around the area to then be able to do your loading, to be able to do your range of movement, to be able to do your endurance stuff. So it's, you know, part of that package of care. With degenerative tendons, I'm less likely to put needles into the degenerative tendon. There's some thought around your tendon now starting to be less structurally I was going to say structurally intact. That's incorrect, but I guess it's a little bit more weakness of the integrity of the tendon. So I'm probably less likely to start sticking needles into the tendon itself because maybe you're more likely to cause a lot more permanent disruption. I don't know of anybody causing a rupture of a tendon, but you know, I can see that because the tendon's not as healthy as it would have been even in the dysfunctional phase. So I'm probably going back to the stuff I would do with me reactive tendinopathies, which is needling in and around the area, hoping to get rid of some of those residual inflammatory markers. And again, it's about that kind of pain management stuff, trying to do the loading elements as well. But, you know, putting a bit of realism into this and saying, you know, we're probably not going to get rid of this completely, but hopefully I might be able to help you manage your symptoms. Now, from a Chinese medicine perspective, we always talk about blood qi stagnations, right? So we're talking about things that aren't moving as much. And in a reactive tendinopathy, you would probably most closely in TCM think of this as an acute blockage of a meridian. So you would look at the meridians that are going over the area of the problem, the tendon, where does that sit? And you would look at needling acupuncture points very crudely above and below, right? So you'd get its source point. So you're probably needling a point on the foot or the hand, the strongest point in the meridian. So you definitely want to be doing that. You'd probably needle a point above and below. And the idea is that you're trying to just open out any blockages of that meridian to help the qi and blood flow through it. And no problems at all forevermore. In like a dysfunctional tendinopathy and in a degenerative tendinopathy, you're probably thinking more of a chronic, more stagnant problem. So something that's just not moving. It's very sluggish. It's stuck down. So on top of the meridian type stuff, you'll be leaning towards the spleen, because the spleen is very much about sluggish and things that are not moving very well. So things like spleen 6, spleen 9, spleen 10. You'd be looking at stomach 36. You'd be looking at stomach 40, because these points are specifically quoted for that kind of stagnant, not moving very well, things that are kind of stuck down in one place. We're kind of trying to like almost like invigorate the thing to kind of move itself on. The thing I would advocate, though, whether you're doing like a Western or a TCM perspective, is gallbladder 34. Now, gallbladder 34 in traditional Chinese medicine is quoted to benefit all soft tissues in the body. So although gallbladder 34 is located at the knee, just anterior and inferior to the fibula head, I would be thinking about gallbladder 34 for any muscular problem whatsoever. So if that was a trigger point problem, if it was a problem with a tendon, obviously what we're talking about today, I would be thinking about gallbladder 34 being added into my recipe. So if you're doing an elbow tendinopathy, if you're doing a shoulder tendinopathy, and you're thinking about putting your points local to the area, yes, please do that. Both TCM and West would agree with that one from different viewpoints, but they would still come up with the same points. Whack in a cheeky little gallbladder 34. Your days would be magnificent. You will think back to the days when you didn't use gallbladder 34 and say, what a fool I was. What a fool I was. It was like walking around in life with just one shoe on. So in terms of other acupuncture points that you might think about, large intestine 15 for the shoulder, that's kind of like thought to be a good tendinopathy point. I've already mentioned gallbladder 34 and stomach 36. Those two would be big ones I'd use in almost all of my tendinopathies. You've got your big ones in the hands and feet, so large intestine 4 and liver 3. If you're a bit stuck, you're like, I'm not really sure what meridian's going over here, or the symptoms seem to be really widespread. If it's a lower limb problem, go liver 3. If it's an upper limb problem, go large intestine 4. Keep it nice and simple, right? If there was something which is like a lot more chronic, so there was a scenario where it's not just this tendon problem, this person seems to have a lot more comorbidities, there seems to be a lot more health issues going on. In Chinese medicine, you might also consider this to be a qi deficiency. I've spoke about this on a number of podcasts, that qi deficiency is linked heavily to a kidney deficiency. So a kidney 3, a bladder 23, particularly kidney 3 would be a really good place to go to add in if you thought that this person's constitution, everything about them seems to be a lot weaker. So that could be another one you could add in your kidney 3. A couple of other things to add in. Tendinopathies, I'm almost always combining with me dry needling approaches. So I'm almost always bringing in whatever muscle belly is affected. I'm thinking about combining my dry needling with my acupuncture. I'm usually approaching this from the gentle needling approach rather than an aggressive, vigorous needling approach, because we're trying to get longer term changes here. All right. So I'm thinking about the gentle dry needling approach on trigger points and then combining that with acupuncture. Chinese medicine, you might call those ashe points. Ashe points don't necessarily have to be trigger points. They're just tender spots. And I think that's it feels like really like just what it hurts there. Just stick a needle in. Like literally that's what it is, right? That hurts, stick a needle in. You've always got to put your acupuncture points in, right? Don't just put ashe points in. Don't just put gentle needle and trigger points in, because you're not going to get as good of an impact. But those, for me, with tendinopathies, react really, really well. So it's a nice little addition to have in there. So, guys, there's not a lot of evidence base when it comes to acupuncture and tendinopathies. There are out there. There's certainly not to the quality or outcome standards of things like migraines and chronic pain. But there are studies out there. There is some support for this. Anecdotally or from a clinical level, there's definitely people who respond exceptionally well to tendinopathies. And how I'm thinking of this, as I've kind of really hit home today, is I'm combining this with other interventions. If somebody's coming in, this is like a low grade 2, 3 out of 10 tendinopathy, I'm not thinking about acupuncture dry needling. If somebody's coming in and they're talking like 7, maybe 8 out of 10, I'm definitely thinking about acupuncture dry needling, because I'm going to calm that thing down. They're going to get on the side. They're going to say, oh my God, Carl, you're fantastic. Not only is super handsome, but you seem to know what you're doing, because my pain feels a little bit better. The more likely to buy and get on board with the other stuff that you're trying to get them to do. So again, as always, and as almost every podcast asks, please make a comment, even if that's just a thank you. right? If it's a really like this specific thing that you did there, whatever. I guess the more feedback we get on this, the better that we can make this, and the more we can tailor this to our audience. So we're constantly working on the feedback from you guys. You just clicking the like button, you sharing this video, you making a comment, even if it's just a cheers, thanks, Carl, you look great, right? Or Carl, you don't look so great. I don't care, right? Anything that kind of stuff really helps us to know that it's helpful. It's something that you want to know. And if it's not so helpful, or you want to know a little bit more about something in particular, or want me to spend more time on something, that's your opportunity to do it. Do it on the podcast stuff, on like, comment, and share, right? Thank you very much. I appreciate your time, and I really hope I've made a difference in some way to your practice. Good luck.